So, third and final case.
Mm-hmm.
So we've got a 78-year-old female who, day one post-open cholecystectomy, starts complaining of chest pain.
Yeah.
And you've been asked to see her on a ward. So,
Okay.
once again, the nurse, you speak to the nurse and you've asked them to take some observations.
Yeah.
Because you're quite good at this now. So his blood pressure's 144 over 88, heart rate's 154, the respiratory rate's 24.
Yeah.
Their SATs are 92% on air, and
Yeah.
their temperature's 38.5.
Okay.
So from this, what do you think?
This patient's unstable.
Yeah.
Very unstable.
So, what are you going to start? What sort of structure are you going to use here now then?
So instead of a history and things, I'm just going to go straight into an ABC.
Yeah.
So you do assessment.
Yeah. So you do your ABC assessment.
Yep.
So obviously you'll start with the airway.
Yep.
And their airway's patent.
Okay.
And then speaking to you in full sentences.
Yeah.
Given that the SAT's 92.
Yeah.
What would you like to give?
Just pop the oxygen on straight away.
Yeah. Yeah.
And then we just have a look at the chest to see if it's expanding equally and auscultate it to see if there's any crackles or.
Yep.
And then percuss for any pleural effusion, which is there in this patient?
So there's not been any. There's definitely some crackles that you can hear on the lower left base of this patient.
Left base. Yeah. Okay. And then I do see. So obviously I'm going to listen to check the obs, but we already know he's tachycardic and his blood pressure's relatively stable.
Yeah.
And then we feel for his pulse.
Yeah.
So is it a regular pulse? Or?
Yeah. So in this patient, it's actually irregularly irregular.
Okay.
So obviously you're thinking of atrial fibrillation.
Yeah.
What else would you like to do on C?
So we can pop a cannula in and take bloods off that.
Yeah.
And then, given his spiked temperature, we can get some blood cultures off him as well.
Yeah.
Yeah. We could give him some. Well, we could give him some fluids, but given that his blood pressure is pretty stable, we could hold off on that for now until we've got the diagnosis.
You can do, but the thing about septic patients is they're constantly losing fluid. So I think it's
so get it in.
Yeah, because of the mechanism, it's still worth giving some fluids. So just going back to the bloods, which bloods would you like to take?
So FBC, UNE, CRP. We can get clotting as well.
Okay, and why are we going to take the FBC in this one?
So his spiked temperature, so I'm thinking it's the sepsis, so check his white cells and his neutrophils, and then get a separate CRP as well.
Yeah. Yeah, so I think that's definitely one of the main ones that you want to look at. And I think the UNEs are quite important in this patient as well, given that they're possibly an AF.
Yeah.
So we need to see if there's any sort of electrolyte abnormalities that could be causing this. Okay, so the nurse has put some 15 litres of oxygen via the non-rebreathe mask. So you've cannulated them and you've got some fluids up. On your D&E assessment, what would you like to do?
So D, check a temperature, we've already done that. Get an AVPU or /GCS. And then we can check his pupils. And we can also, I can't remember whether I've already felt his abdomen, but I'd feel it now.
Yeah.
And check his calves as well, see if they're soft and tender.
Okay. So given that we know that they're spiking a temperature, what sorts of things would you immediately like to start?
So give him some something like paracetamol to bring his temperature down.
Yeah.
And antibiotics, broad spectrum.
Great. So now we've got the patient a bit more stable now with all these measures. What would you now like to go back and do?
So I can then take a history off him.
Yeah, so we want to go back and take a proper history, really.
Yeah.
So if we go back to our Socrates.
Yep.
So go for it.
Where's this gentleman's chest pain?
So the pain's sort of been it's been kind of in the centre of the chest, but also around on the right.
And when did his chest pain come on?
It's been going on for about the past week or so, but it's been worse. It's gradually getting worse.
Okay. And how would you describe his chest pain?
It's quite sharp.
Does it go anywhere else, the pain?
It sometimes goes around to the back a bit.
Okay.
That's about,
and has he had any associated symptoms, particularly cough or shortness of breath?
Yeah, so actually he's been coughing up quite a bit of green sputum for the past week, and has been quite short of breath actually.
Okay. Has he been feeling feverish?
Yes, been really hot and sweaty, and I think actually the nurse mentioned to us earlier that we've actually got a temperature, don't we? So
Yeah.
yep.
And so the timing, is it there all the time?
It comes and goes, but it's it's gradually becoming worse and worse. So at the moment it's quite constant.
And is there anything that's making it worse?
Nothing that she can pinpoint. No.
Okay. And what would the patient give it out of 10, the pain?
It's about a 7 out of 10.
Okay.
Yeah.
And then obviously I want to know past medical history.
Yeah.
So does she have any...
Well, before that we want to ask if you've ever had this pain before.
Oh yeah, okay. So has she?
So she hasn't had this particular pain before, but she had a chest pain in the past because she had an MI in the past.
Okay.
But it's not. But this pain feels a bit different to that.
Yeah.
Okay. So yeah, sorry. Past medical history.
So, yeah, has she got any ongoing health problems?
So she's got. So we know she's got a previous MI. She's known to have atrial fibrillation. She's got osteoarthritis, and she's also got hypertension.
Okay. Any medication that she takes?
So she's on ramipril, Adcal, warfarin, simvastatin, bisoprolol, and aspirin.
Does she have any allergies to any antibiotics?
No, she
Good.
doesn't have
You've
any
already
allergies.
given us some penicillin, so...
Yep. From that drug history, what's quite important there?
The fact she's on warfarin.
Yeah,
so
definitely.
Obviously, I think I mentioned clotting, but particularly we can check her INR because septic patients can get deranged INRs.
Yeah. And also some antibiotics, such as ciprofloxacin, affect your INR. So we need to make sure that we're aware of that before we prescribe it. Okay, and then you're also going to take a bit of a social history, and I'd tell you that she lives on her own at home and she's quite frail. She's got carers sort of once a day. She's never smoked and she drinks rarely.
Okay.
So now we've done a bit of an examination already, haven't we?
Yeah.
But I think you'll go back and do a bit of a thorough examination, won't you?
Yep. So we can obviously start by general inspection. How she's looking generally in the bed. Is she short of breath still? She's probably stabilised a little bit with the treatment we've started on. And then have a listen to her heart sounds, check a cap refill time. Feel her pulse again. And then particularly with the chest, we want to listen for any areas of consolidation, crackles, and percuss as well for any pleural effusions. I think we mentioned earlier she had some left basal crackles, so one thing in the back of my mind is we want to get a chest x-ray.
Yeah, definitely. So we've done our examination, so now let's look at the blood tests. So this lady, her hemoglobin is 134. Her white cells are 15.4. Her sodium is 143. Her potassium is 4.6. Her urea is 3.8. Her creatinine is 102. Her EGFR is more than 90. And her CRP is 102.
102.
Yeah.
Okay.
So what are you thinking about this?
So it's pointing towards a likely infective process, although she's also day one post-op, I think. So we just have to bear in mind.
Yeah.
Inflammatory markers may be raised. But given the history, this is likely to be an infective process. So I'd also like to get a chest x-ray and an ECG, just given she's tachycardic and we've got a history of AF as well.
Yeah.
So that may be something we can correct.
So her tachycardia before was about 110.
Yeah.
But while you're chatting to the patient, you've also asked the nurse to take some repeat observations.
Okay.
And her tachycardia has actually just gone up to about 154.
Okay.
So obviously you'd ask for an ECG. So here's the ECG for this patient, and what does it show?
So her rate, obviously here she is tachycardic. So her rate's showing about 150. Her rhythm is irregular.
Yeah.
And it's irregularly irregular. The axis is normal.
Yep.
So it's not sinus, but can't see any P waves on it. So this is likely to be fast AF.
Yeah. So we know that she's got AF anyway,
Yeah.
And she's normally controlled with the warfarin. But obviously this lady, it's probably the sepsis that's driven this into a fast AF. So first thing you're going to do is
call for someone, particularly the med reg. Well,
yeah.
I'd call the surgical reg first.
Yeah.
And then likely the advice would be to call
the medical reg. Yeah. When we manage fast AF, you split it into two things. If they're hemodynamically stable, or if they're hemodynamically unstable. So this patient the blood pressure is quite stable at the moment.
Yep.
Even though we're just giving them a bit of fluids to help, but they're hemodynamically stable. So essentially, the medical reg advises you to treat with either oral or IV beta blockers, such as bisoprolol or metoprolol. And if there's no response, you give amiodarone. But obviously, these aren't things that you'd be expected to do.
No.
The medical reg would come and assist you with this.
Yes.
And if they were hemodynamically unstable, then they usually require urgent synchronized DC cardioversion.
Okay.
So you've been really lucky. You've got a great med reg, and they've come and they've sorted out the patient's fast AF.
Yeah.
And you've had a repeat ECG, and now their rates come back to normal.
Okay.
Okay. So you've got another chest X-ray here.
So the airway looks clear.
Mm-hmm.
Bones, I can't see any obvious fractures, rib fractures.
Mm-hmm.
The heart size looks normal.
Yep.
There is no pleural effusion. Diaphragm looks normal, reasonable height. But there is some patchy consolidation.
Yeah.
On the right side.
Good. Yeah. So what do you think this is probably going to be?
So pneumonia, given the history and the chest X-ray changes.
And given that this started, obviously they've only come in for a day ago for their operation, so it's likely to start in the community.
Yeah.
So it's likely it's a community-acquired pneumonia. But you've very rightly started them on sort of broad spectrum antibiotics as per the hospital guidelines.
Yeah.
And given that now you know it's a community-acquired pneumonia, you can look at the guidelines and see, according to their curve score, which are the right antibiotics for them.
Yep.
Good. So they were the three cases. So we've talked about the cause of chest pain across the different systems.
Mm-hmm.
And I think one of the key things that you've been bearing in mind, and that is always important to bear in mind, is that you should work the differentials and rule them out as you go along in your history taking and in your examination, and use the investigations to narrow it down further. And obviously the most important thing is the life-threatening causes that you need to make sure that you ask all the right questions and do all the examinations for. You need to have a good structure to your history and your examination. It's always useful to use things like Socrates as you go through, and you're much less likely to miss the important things. And obviously if they're stable, then you're going to do, you can take your time and do an assessment thoroughly. But if they're unstable, obviously go straight for your ABC assessment, which you did. And I think one of the most important things is always ask for help if ever you feel out of depth.
Yeah.
You'll never be criticised for that.
Definitely.
Any questions, James?
I don't think so.
Good. Okay. Well, thank you very much.
Thank you.